It's been great to come here and see some old friends, actually, and to also meet a lot of new people, and that's very exciting. You know, just being at this meeting, seeing the quality of the talks, just meeting with the people here, and seeing the great turnout you have, I can see why everybody here is so proud of the UCLA and the Doheny tradition. So I start in about a week and a half, and I'm very excited to be a part of this family. So with that, I'll get started with my talk, which is really looking at a paradigm shift that we're having in the treatment of proliferative diabetic retinopathy. So I would say over the last 8 to 10 years, we've had a real paradigm shift in our management of diabetic macular edema. So it's really, for many decades, really focused on laser photocoagulation of macular edema, and now recently it's been shifted towards the treatment with anti-VEGF. And a similar paradigm shift has been happening with proliferative diabetic retinopathy as well. It's much more recent. It's really been just over the last 1 to 2 years that we're really changing our paradigms in the management of proliferative diabetic retinopathy. My disclosures can be seen here. And we know that diabetic retinopathy progresses or worsens in these very discrete levels as defined by the early treatment diabetic retinopathy study. Much of that work has been done at the reading center that I'm currently at for another week and a half, which is the Wisconsin Fundus Photograph Reading Center. A lot of that seminal work was done by Dr. Matthew Davis there. And what he and his group described very early on was looking at the progression of diabetic retinopathy, going from microaneurysms to venous beating to hemorrhages and heart exit to hemorrhages in all 4 quadrants. And you know, when you talk to him, he'll tell you it was not very obvious how diabetic retinopathy progressed at the time. And then when you do careful study of this, then only then does it actually become obvious. And you can see right now our paradigm waits, and we watch patients go from microaneurysms to mild NPDR, to moderate NPDR, and then to moderately severe, and then severe NPDR. And then we wait until they cross a threshold into that red area, until you get frank neovascularization, before we actually do anything about it. That's our current paradigm. So it's a kind of a watching and waiting paradigm. And it's based on some very successful data that was seen from the diabetic retinopathy study. And you can see that patients who have pan-retinal photocoagulation have their risk of severe vision loss cut by approximately 50%. So this is the bedrock of what we've based our management of proliferative diabetic retinopathy on for many, many years. And it's an effective therapy, but I would argue that it's also an inherently destructive therapy. So if you look at this page, this is a patient I took an optos photograph on recently. It's a patient that I've been following for well over a decade. Patient comes in with recurrent vitreous hemorrhages. You follow it up with pan-retinal laser photocoagulation. And indeed, this patient is doing well. The patient is actually seeing about 20/25. And I would say, yes, the patient is doing well, but I think if you study this patient carefully, he's going to have significant visual field loss, probably some degree of macular edema, some degree of central visual loss, probably some degree of nyctalopia and dyschromatopsia because of all the intense pan-retinal laser photocoagulation. So in the era of anti-VEGF, there are really 2 important questions that we have regarding the current algorithm. One is, do we have an effective and less destructive therapy to use in place of pan-retinal laser photocoagulation when a patient develops proliferative disease? And the second one is, do we have a safe and effective therapy to prevent proliferative diabetic retinopathy from developing in the first place? That is, can we intervene earlier? And I'll tackle the first question first. Do we have this effective therapy? And I would argue that at this point, it points to the fact that we probably do. And I'll give you some anecdotal evidence, some evidence from some secondary evidence from clinical trials, and also some evidence from randomized controlled clinical trials that are looking specifically at this question. So here is an anecdotal case. This is a case that came out before any of the recent clinical trials, and this is a patient of mine that I saw in the clinic, type 2 diabetic, vision 20/20 in the right eye, 20/125 in the left eye. And you can see the OCT in the right eye has some mild distortion of the foveal architecture, but in the left eye, there's diabetic macular edema with intraretinal hemorrhage, intraretinal edema, and subretinal fluid. Trying to advance the slide here. And here's the color fundus photograph. And I don't know if you can see it in the back of the room, but there's at least a disc area of neovascularization just temporal to the optic nerve. So this patient has concomitant high-risk characteristics proliferative diabetic retinopathy. So per the DRS criteria, this is a patient who is eligible for pan-retinal laser photocoagulation, something we teach to our residents day in and day out. This patient was treated with one Avastin injection in the left eye for the diabetic macular edema, and you can see that the visual acuity has improved to 20/80, and the foveal architecture is improved following the Avastin injection. But very interestingly, on the color fundus photograph, this is after the first Avastin injection, the neovascularization has completely resolved. So technically now at this point, this patient does not have high-risk characteristics proliferative diabetic retinopathy. And to make a long story short, this patient had been re-injected several times for the diabetic macular edema as per our protocols for diabetic macular edema dictate, and this patient has never had to have pan-retinal laser photocoagulation. So that's an anecdotal case. And as I mentioned, I'm going to show you some secondary outcomes data from clinical trials. This is from something called the RIDE and RISE trial, primarily looking at the injections of ranibizumab for diabetic macular edema. And this slide essentially shows here on the far right of the screen that patients who are exposed to multiple injections of ranibizumab over a 2-year period of time have highly statistically significant improvements in their retinopathy level compared with those patients that receive only sham injections. And an easier way to describe this and to show this to you is actually to show you one of the cases from the RIDE and RISE trial. And you can see a patient, one eye, right eye, and you can see on the left side of the screen here, that's a patient who had proliferative disease at entrance, who has only now graded mild non-proliferative disease at month 36 with intravitreal ranibizumab. And I would argue that this patient doesn't have all of those side effects, or at least significantly less of those side effects that I mentioned that patients get with pan-retinal laser photocoagulation. So a much more gentle treatment overall to the retinal anatomy. And then finally here, there is now recent data from a randomized controlled clinical trial looking at this specific question. This was done by the Diabetic Retinopathy Clinical Research Network. This was recently published, and it's termed Protocol S, which looked at ranibizumab versus deferral of pan-retinal laser photocoagulation with immediate ranibizumab for eyes that have proliferative diabetic retinopathy. You can advance the slide, thank you. So in Protocol S, again, prompt PRP, 1-to-1 allocation ratio between prompt PRP versus 0.5 milligram ranibizumab with deferral of pan-retinal laser photocoagulation. So that's the rough study design, and I'll show you some of the salient results. And this study primarily looked at visual acuity as its main outcome. So what it said was, all right, we know that pan-retinal laser photocoagulation is the gold standard, and there are certain visual results with that. And the new kid on the block is intravitreal ranibizumab for proliferative disease. So the study question is the application of intravitreal ranibizumab compared with pan-retinal laser photocoagulation with ranibizumab, is the visual results non-inferior to pan-retinal laser photocoagulation? So you can see PRP on the white on the bottom, and then the ranibizumab line with respect to visual acuity. It certainly meets the non-inferior visual acuity margin because it's on top of it, so the visual acuity is actually slightly better. Additionally, if you look at area under the curve, the time spent with better visual acuity in the ranibizumab group was greater. There's a greater area under the curve compared with pan-retinal laser photocoagulation. So the visual acuity results are better. Also, looking at those that develop diabetic macular edema, it was greater in those with pan-retinal laser photocoagulation compared with the ranibizumab group. Yeah, it doesn't seem to be advancing. Dead batteries. It had a lot of use here today, so yeah. Now it's, okay. And so if you look at, they looked at peripheral visual field loss as well, and not surprisingly, there was significantly less peripheral visual field loss in those patients in the ranibizumab group compared with the pan-retinal laser photocoagulation group. And then other complications of proliferative disease. It wasn't statistically significant for any of these with the exception of vitrectomy. So you can conclude from Protocol S, you had 4% rate of vitrectomy for complications of PDR in the ranibizumab group, 15% in the pan-retinal laser photocoagulation group. So we can more often avoid surgery with intravitreal ranibizumab. So let's see, let's go back. So the discussion from Protocol S is that, again, it met the primary non-inferior outcome of visual acuity. It was not non-inferior. It was actually superior over the course of 2 years. There were better visual field outcomes, reduced need for vitrectomy, and reduced development of developing central involved diabetic macular edema. So what do we do? What's our potential paradigm now with these data in mind? The anecdotal evidence that I showed you, the evidence from these secondary outcomes from clinical trials, and then most importantly, data from Protocol S, which was, again, a randomized trial designed specifically to answer this question. Well, I think the conventional wisdom now is that if diabetic macular edema is present, strong consideration should be given to initiation with an anti-VEGF agent because of all these benefits that we're seeing with the intravitreal injections. When you have diabetic macular edema, that's now the conventional standard to treat diabetic macular edema with an anti-VEGF agent. So you're going to treat the diabetic macular edema anyway, it's probably going to benefit the proliferative disease. Now, if you have an eye that has high-risk characteristics PDR, but DME is not present, then it becomes a little tougher. Then you have to think about the patient and their preferences. You have to think about their tolerance for intravitreal injections. You have to think about how likely it is that patient's going to be able to get back and forth between the clinic, because when we apply pan-retinal laser photocoagulation, it's certainly a less time-intensive therapy for the patient and for the clinic. So that tackled the first question. Now the second question is, can we intervene earlier? And if we can intervene earlier, at what point should we intervene? You know, is it too early to intervene when it's only microaneurysms, or do we wait until the patients are just falling off the cliff before we do any type of intervention on these eyes? Well, first of all, we do know that there are systemic treatments and interventions that can reduce the rate of progression of diabetic retinopathy. We know this, right? We know this from many very important public health studies. We know this from the DCCT, the EDIC trial, UK PDS, the Accord, that glycemic control and hypertensive control can reduce the rate of progression of diabetic retinopathy. There are also, and this is kind of doing it on its own now, there are also drugs that can do this. We know this from the RAS trial. Enalapril can do this. We know this from Accord and Field that fenofibrate is also very effective at reducing the rate of progression of diabetic retinopathy. But it's interesting that for some reason the ophthalmology community has not really grasped onto this, particularly fenofibrate. And we all know that systemic control is notoriously difficult to achieve. So while we know we can do this, there are a variety of reasons why these are not, at this point, primary treatments to prevent progression of diabetic retinopathy. So what about ocular treatments? Well, again, this is taken from many of the clinical trials for anti-VEGF that have looked at primarily treating diabetic macular edema. So this slide comes from RIDE and RISE, looking at ranibizumab. And you can see here the ranibizumab groups in the orange and the yellow have a threefold lower risk of developing a composite proliferative diabetic retinopathy outcome. In other words, from photographs or from the investigator saying that there was a vitrectomy that needed to be done or a panretinal laser photocoagulation treatment that needed to be done. So again, threefold lower in the 2 ranibizumab groups compared with the sham group in white. This is a Kaplan-Meier curve showing that this difference held for 3 years. And then there is also data from Vivid and Vista. If we can advance the slide, please. From Vivid and Vista, looking at the proportion of patients that require PRP from baseline to about week 100. And you can see that the sham groups are in gray, and the 2 aflibercept groups, so Eylea groups, are in green and yellow. And their rates of requiring panretinal photocoagulation in this trial were significantly reduced with aflibercept compared with sham. So I think we've answered the question of really, do we have a safe and effective therapy to prevent PDR from developing? But the answers to some questions raise more questions, and that leads to the other question of, we do have one, but if we can now intervene earlier, at what point should we actually intervene? And fortunately, we have some very good data from old clinical trials, the ETDRS, and some newer ones too from Protocol W. Thank you. And this is from the ETDRS, showing that depending on where you started with your baseline level of retinopathy, it shows you that your rate of progression is much higher. So again, you can see here eyes at level 35, just a few microaneurysms. Those eyes aren't going to progress very quickly, whereas eyes that have severe NPDR are going to develop proliferative disease at a very high rate. And so this slide summarizes it's almost 75 to 90% in those eyes that have severe non-proliferative disease. They're going to develop proliferative disease. And so Protocol W from the DRCR net is going to evaluate this. And it shows here, let me just show here quickly here, that they're going to randomize patients into 1-to-1 observation, between observation and prompt intravitreal anti-VEGF therapy to see if we can prevent proliferative diabetic retinopathy from occurring in the first place. So this is an ongoing trial. We're actually trying to set up Protocol W at Doheny, and I know they're trying to do it at Stein too, so we'll have that set up very quickly. These are the eyes that we're looking at. Again, level 53 eyes that have severe non-proliferative disease, and we're trying to see if we can prevent proliferative disease from occurring in the first place with intravitreal anti-VEGF injections. And so to conclude, our current standard of care is to await the development of high-risk PDR and then to treat with a relatively destructive therapy. PRP has served us very well over the years, but current data indicate that anti-VEGF therapy may be an effective treatment for diabetic retinopathy severity and possibly be a replacement for PRP when PDR develops, and possibly can be given even before PDR develops to prevent it from occurring. So I think that just as macular laser photocoagulation has replaced, or has been replaced by anti-VEGF therapy, I believe that PRP is going to also be replaced for many cases of proliferative diabetic retinopathy in the future. And I think we're going to have a lot of studies that are coming out in the future that are going to give us a lot of very, very interesting information in what I think is potentially a game-changing paradigm that is really treating PDR or preventing it from occurring in the first place. So thank you for your attention.